Good morning, everyone. As mentioned today, I'll be talking a little bit different approach. I'll be focusing a little bit about abdominal aortic aneurysm, but honestly, the disparities and outcomes kind of are consistent regardless of which segment of the aorta we're talking about. Those are my disclosures. So when we start talking about aneurysm and aortic aneurysms in women, we have to start by the definition. There is even differences in when we define an aneurysm. So the prevalence of AAA at age 65 is 4 to 5 times greater in men than women. But that depends on how do we define an aneurysm. If we take the aortic diameter larger than 3 centimeters as our definition, then the yield of incidence in women is about maximum 1.3%. But if we define aneurysm as a 1.5 times the normal infrarenal aortic diameter in that patient, that number can go up to 10% in women. So we can see that even by defining a different way in aneurysm or focusing on how we define the aneurysm, the incidence of aortic aneurysm in women is going to be different in how you approach it. When we talk about screening recommendations, the United States Preventive Services Task Force basically recommends screening for men and has no consensus recommendation about screening abdominal aortic aneurysm in women. The SVS does have a recommendation to screen women older than 65 who have ever smoked or have family history of AAA, and those also were added to the guidelines by the recent guidelines in 2022 by AHA and ACC. Those kind of recommendations are based on historical studies that looked at efficacy and efficiency and basically, is it cost effective to do screening for aortic aneurysms in women? But we'll talk about why it's problematic to look at those studies. So even though it is less prevalent in women, we don't really have recommendations for screening. It kind of looks like, it's a disease for men and not really for women. When we look at what happens when a woman develops an aneurysm, first of all, they're older when they present or they get into surgery. Once they develop it, it's a more aggressive disease, more rapid expansion, have a higher tendency to rupture at smaller diameters, and up to 4 times likely to rupture during surveillance compared to male patients. When they do rupture, they have 3-fold higher mortality rate, even when you adjust for age. So that's not because women are older. And when we talk about percentage of women versus men presenting with rupture, women present higher percentage than men. This kind of data is also consistent when we talk about thoracoabdominal, when we talk about ascending in the arch and thoracic. So basically, women do worse when they develop aortic aneurysm, whether we do repair or surveillance. So what about outcomes when we treat? Again, across multiple publications in the literature, women have higher mortality in open, even in elective repair, not just in the rupture. In the endovascular repair, when we look at it, women have a higher risk features, anatomical risk features. They are most likely to have a smaller iliac artery diameters, less than 6 millimeter, shorter necks, as well as higher angulation in aortic neck. So again, higher risk features compared to men. So looked at 2 recent studies that looked at the outcomes between men and women in open and endovascular repair. This is a study that looked at SVS-VQI database, looked at 50,000 patients, with the majority of them having EVAR, about 80% of them. Women, despite that, women had a higher percentage going under open, and that was consistent across when you look at even thoracoarray endings. Women usually are declined endovascular repair, again, for the reasons that we've talked about anatomically and are more candidates for open. They are more likely to present symptomatic. And they were more likely, when they do open surgery, they were more likely to have an above renal clamp, an EVAR, more conversion to open, with the risk of renal artery coverage or needing to add renal stents. And they had, as we've mentioned before, also in this study, higher neck angulation and shorter necks, with a higher 30-day mortality in both EVAR and open surgery. This study looked at the registry of the German Society of Vascular Surgery, looked at 23,000 cases. Again, majority are men, but still women, we can look at that. Women had smaller maximum diameter, but when they looked at the aortic index, looking at the body surface area as well, that was higher in women. Longer ICU stay, longer length of stay, and higher mortality in both open and EVAR. No, that was statistically significant. Anatomical factors we take into account. This is a suggestion for an anatomic factor for severity score to look at how the anatomy you can calculate and see risk of failure of endovascular repair, and women usually women scored higher in this as well. And again, a predictor of failure of endovascular or possible complications. So when we look into all of that and we still want to treat women, we want to consider an endovascular repair, this is an important factor to look and understand your devices and know the devices. I'm not going to go into all the devices and give you an example of it, but it's important to focus on certain things. So you need to know things that matter for the aortic neck. Women have smaller aortic necks, so you need to think about devices that have smaller diameters, have more flexibility due to the angulation of the neck, ability to reconstruct and have partial deployments in order to have more accurate deployment as well, especially when you have shorter necks, thinking about ability to have control of the proximal end so you can, for the angulation. And you need to understand the IFU indications for length. Women are most likely to be outside of IFU use when you're using endovascular repair, but it's still important to understand each of your devices, what are their indications for the shortness of the neck, which devices are indicated for shorter necks, because those are things that you might want to consider when you're considering endovascular repair. What about access? So iliac diameters, as we said, again, you want a delivery system that has a smaller profile in order to consider it when you're repairing in women. It's also important to think about the flexibility and the tortuosity, because women have more tortuous iliacs as well, and so you want a device that is able to take tortuosity and able to access small vessels in deployment. These are just a couple examples of patients I've had. They've had long necks, but you can see the angulation in it. So it's important for me when I chose a device here to be able to have a device that would take that angulation, and I can fix it in a way where you can basically have a good seal in it. This is just to show you, this patient also had an angulation in the neck, but her iliacs were also complete. Like this is 180 degrees and then another. So it's important to be able to have a device that can be flexible and can go up. Sometimes it's tricky, challenging. During the device deployment, you might have to reposition it if it falls down. And so it's important to think about these things. So when we're thinking about women do worse, they rupture when they're watching. So what about thinking about doing an early repair? Maybe the approach should be that we should fix it smaller diameters earlier before it gets to the rupture and maybe improve the mortality. Well, most of the studies that have looked at it historically, and they're listed here, the UK small aneurysm trial, the Adams trial, and others have looked into it, and they did not show any benefit of early repair of 4 centimeters to 5.5. However, when you're looking at those studies and the representation of women in it, women were very underrepresented in it. And it was just shocking. I want to just put here an example of the representation of women in most of the trials that we actually base our guidelines and treatments on. Women had been less than 10% in the majority of the trials. There are a couple of trials that there was not even a 1% of the patients that were included that were women. So basically we're basing our indications, our protocols, and our treatments and guidelines based on studies that had underrepresentation of women. So where do we go from here? One thing that I'm looking forward to is a trial. I can't take the credit for it. I'm hoping that we're going to be a site for it. This is courtesy of Dr. Shaprara. This is a Warriors trial. It's women's aneurysm research. It's an international study that's going to look at a randomization and comparison of repair of abdominal aortic aneurysm in women versus watchful kind of follow-up and treatment for women who have a 4 to 5.5 centimeter in aneurysm size. The goal is to try to include over 1,000 women in that and to look into that and kind of see if there is any difference. This is the team that are leading it. Dr. Adam Beck and Shaprara are going to be the national PIs in the U.S. I'm looking forward to the outcome of that study because I think this is the first study that's going to be focusing on infrarenal abdominal aortic aneurysm with the design specifically thinking about women. So in conclusion, when I look about how do we approach and what do we need right now for aneurysm disease in women, we know, and that's out there in the literature, we can't really deny that anymore. Women do worst outcomes in both open and endo, so whatever we have right now is not a good solution. We might need to think about risk factor modification and early screening. I didn't go into that for the sake of time here, but there's a lot of studies that show that even at adjusting risk factors, there is disparities. Women are usually not well controlled with their hypertension. They're not following guidelines treatments compared to the men with the same disease, with the same PCPs and primary care physicians. So there are disparities in even risk factor management in women compared to men, and we might want to start with that. The screening protocols, as we've mentioned earlier. And then anatomy matters. We need to think about it when we're designing our devices and take into consideration special things that matter for anatomy in females, and that's something that needs to kind of go when we're talking into industry and we're talking to develop new devices for that. Anatomy does not matter alone. There are other things that matter as well here, hormonal and hemodynamics. Again, I didn't go a lot into that. There isn't a lot of research on it, but there are some that hint that also the hormonal roles have an impact on it. There were studies that showed that women who had early menopause basically had a higher incidence of abdominal aortic aneurysms and ascending. So there is room to look into that even more. And so my message is we can use what we have today and consider taking into consideration everything that we know. But I think the biggest message is that we need new trials with sex and gender specific considerations while we're designing the trials, because I think that's where we're going to get the answers to improve our management. Thank you.